Right, good evening, everyone. I think let's get started. Others can join us as they go along. We are currently in week 7 of our Rudasa Rural Onboarding webinars. For those who are interested, you can also have a look and check out the Rudasa website, which we'll post again in the page. I see someone says it's not working. I'll quickly just check that link myself and potentially add that on. And you can also have a look at the YouTube page for previous webinars from this year and from previous years as well. There's a host of amazing information and amazing webinars there as well. It is my absolute pleasure to welcome Dr. Hennie Lategan. Hennie is an emergency specialist physician. He did his undergraduate training at the University of the Witwatersrand and did his postgraduate training at UCT. Where he has an MMed and he is a fellow of the College of Medicine of South Africa, of Emergency Medicine of South Africa. Hennie, from what you can see, has got a passion for trauma, has a passion for battlefield medicine, a lot of experience and knowledge in austere environments, including diving medicine, and he has been very involved with research in that as well. Hennie currently heads up the trauma emergency unit at Tygerberg Hospital. I have spent some time there when I was a registrar. In fact, Hennie was one of my first ever consultants and played a huge role in my own journey and development and has taught me a lot about what I know about trauma and emergency medicine in general. And I think we are really in for a treat tonight as he updates us with what is happening in the world of trauma, especially regarding fluids and blood and what the current updates are and what best practices. So when you are ready, Hennie, I'm going to hand over to you to share your screen and to take us through. Thanks so much.
Thanks. Hi, everyone. Can you hear me? You don't necessarily have to see me.
You are audible and we can see you.
All right, so let me just share the screen. Oh, no. That didn't work. I was earlier able to share. Now I can't seem to share.
Not seeing anything just yet. Have you managed to click on that share button at the bottom?
It doesn't help. Is that working?
It's not.
I'll try there. Got it.
There we go. Yep.
Yeah, okay, so we're sharing, yeah?
Got you, yes.
Okay, good. All right. Hi, everyone. My name's Hennie. As Sean mentioned, she was one of my registrars. Yeah, so we've got an interesting history. Let's just get started. Sean, how much time do we have? About an hour.
You've got about an hour, yeah. Thanks, Hennie. We'll do questions at the end as well.
Yeah, so I'll try not to be too long. So really what we're going to talk about is just the current fluid trends and trauma worldwide and what we're doing at Tygerberg. And as you can see, it's freeze-dried plasma and whole blood. I thought I'd show this picture. This is World War II, a little dog getting freeze-dried plasma, which I thought was quite interesting. Just to kick off the lethal diamond, we all know and we're taught the lethal triad. It's now the lethal diamond. What has been added is hypocalcemia. So we all know acidosis, coagulopathy, and hypothermia. Hypocalcemia is added. Within our fluid therapy, we're trying to change or correct the acidosis. We're trying to correct the coagulopathy. And hypocalcemia will just be an adjunct. And of course, our beer huggers and warming for the hypothermia. Just freeze-dried plasma. At the end of the talk, we can talk about who knows about freeze-dried plasma, who's used it. There's only 3 countries in the world that manufacture it. It's South Africa, Bioplasma. It's a company in Durban. Then there's the French product and the German product. Can you guys see my mouse, the little arrow? No. Sean, not really.
No, we can see it. We can see it.
Can you see the little arrow? Okay, great. So the French product, our product, South Africa, and then the German product, Bioplasma has been manufacturing freeze-dried plasma since 1995. I started using it as an intern in 2003 in Northwestern Rustenburg. mainly for the obstetrics and gynae patients. In and around 2010, we started using it for trauma patients. Just a reminder what it isn't. So we all know FFP, fresh frozen plasma, something that we've used quite often. The problem with FFP is that the volume is large, it's expensive. You're looking at about 5,000–6,000 rand. And then you need to thaw it. So it needs to be frozen and then it needs to be thawed, and that takes time. And in our acute resuscitations, that's not exactly what we have. So the products related to plasma, right, is fresh plasma, FFP. We're focusing on freeze-dried plasma today. Cryoprecipitate we do use in trauma resuscitators, but it is very expensive. And then the rest of the products for non-trauma. Just the history of freeze-dried plasma, very much used in World War II. From the picture I showed you, 1949, production went up. Indochina War, they used it as well. Then in 1995, obviously the HIV came out and it became an issue. The Gulf War, they used a little bit, not too much. 94 picked up, and then 2010 picked up. Again, a nice picture. And the reason I also showed this picture is that you can see that it was and still is a glass bottle. A lot of guys ask me, especially the pre-hospital military guys, can't we put it in, like a vacuolator type thing? And currently the answer is no. It has to be in a glass bottle. The freeze-dried plasma, what's great about it, innovative, that from the shelf, 5 minutes to infusion. We generally do it within 3 minutes. If you look at the video, it's definitely less than 5 minutes. So it's going in nicely. And what we show our students, and it's always a student or a helper that's mixing it, that make sure that the vacuum section is in the bottom, and that's your water. Make sure you don't put the needle unattached to the water first, then you lose the vacuum, then you're stuck. Then you have to draw the water out with a 50 ml syringe and squeeze it in, and that will definitely take more than 10–15 minutes. One of our trauma nurses at Tygerberg actually made this little device. So instead of standing and holding it or letting students do it, we just place the 2 FTP bottles at the bottom, the water on the top, puncture them, and then it runs through, and you've got 2 bottles within 3 to 5 minutes, which I thought was great. He made this himself. Just in terms of what's the international opinion, what's going out there, what do people think about freeze-dried plasma? There's a big military movement towards it, pre-hospital military, and to an extent civilian. I thought this quote was very apt. If you read here, one old retired army physician. After 34 years of service, I cannot identify a more important medical product needed by our military today. So remove military and say pre-hospital and trauma care. And that's where we are today, is that it's extremely, extremely valuable product and very well suited for LMIC and also suited for rural district regional CHCs, not so much tertiary facilities. The dried plasma, if you have a look here, whole blood has several disadvantages. We'll go through that. The dried plasma, if properly stored, keeps for at least 5 years. So we have a 5-year shelf life. If protected from light, there we go, is your 5 years or below 20 degrees, and it can be given to patients with any group. So there's no cross-matching, typing, or anything, what have you. So one of the major advantages of freeze-dried plasma. We already mentioned where is it sourced from. So in the Western Cape at least, the Western Province Blood Transfusion Service, we have blood donors. They donate blood. The WPBS then takes the blood. They will put it into the various constituent factors, packed cells, platelets, plasma, etc. And then it's actually a byproduct. We visited the new center in Pinelands about a year ago. And interestingly enough, their so-called, in inverted commas, waste gets sent to Durban to this company, Bioplasma. And with that, they then make the freeze-dried plasma. So what's important to note is that that bottle could be 20 donors, it could be 100 donors, we don't know. The good thing in South Africa is that our blood products are tested on multiple levels throughout its journey for infective markers. So the donor gets tested when given, then when they split it up into the components, it gets tested. when it's finally leaving and going to bioplasmin derm, and it's probably been tested 2, 3, maybe 4 times. So from a perspective on infectivity risk, bioplasmin FTP South Africa is the safest compared to the French or the German products. There was a symposium in France where they were discussing FTP freeze-dried plasma. Bioplasma was highlighted. As we said, it's pooled of unpaid donors, universal blood group compatibility, not too many studies in cardiac surgery. This is the French product being used by the US military. The US military at this stage only allows the special forces groups to use freeze-dried plasma. It's not allowed as yet throughout the broader military. We went to a conference in the United States in 2024. It's called SOMA, Special Operations Military Association, and we actually presented on our findings in FTP in our EPIC study, which I'll expand on a bit later. But funny enough, we had one guy presenting on one unit that he had given to a soldier in the field. He had a whole 45-minute presentation on, this is what I did, this is how I mixed it up, and gave it to the patient. Everyone was like, wow, wow. And then myself and Prof. Mikofi presented our findings in our study using FTP day in and day out for the last 10 years. Everyone couldn't quite believe that we were using it so much and the good outcomes that we can. So a slightly older paper, just going through point of injury. So a lot of the current research, except at Tygerberg where we've got hospital research, there's pre-hospital data on freeze-dried plasma use. It makes a lot of sense to have it in your ambulances, a lot of sense to mix it up on site and then transport the patient to definitive care. So sure, we've got some good evidence to show that. Is it the solution for trauma casualties? One of the papers, yes. No, it is. The IDF has been using it a lot, and they've got a lot of pre-hospital data on FTP use. This was really just to show the study supports the uses of FTP at point of injury in the pre-hospital setting. So where does it differ? We're at Tygerberg. We are not a pre-hospital setting, but we are an LMIC country. And we've got a current study studying freeze-dried plasma and whole blood. And we're already publishing on what we have, which is why we're doing the talk. Right? So the same symposium in 2015, just going through that it's a novel component, freeze-dried plasma. This is 2015. Now, 11 years later, it's not so novel, at least in South Africa, but internationally, they still feel that it's novel. This article read from the Journal of Surgery is it's not your grandfather's field plasma. It is, but it isn't. It's more refined, it's more cleaned, in inverted commas, it's more disease-free. So it is your grandfather's plasma, but it's a lot more refined as a modern product. This is 2023, if you guys look on the top there. All right, so the Association of Freeze-Dried Plasma, 24-hour mortality and trauma patients at risk. This is what we published from our EPIC study. We are looking at trauma patients from point of injury, the EMS journey, in-hospital journey,
Hennie, sorry. I think we keep losing you.
And then possibly to death. Patients since 2020. We have a lot of data. We have a lot of data on the injuries, fluids given, treatments, and outcomes. And we published works. Doesn't work as well. Yeah. Should I just carry on?
Maybe switch off your video. Let's see if that helps. It may also be me.
It is off, I think.
Just every now and then we were just losing you and just freezing a bit. Wait, let me try turning off your video for you. Maybe that'll help. I think I can do that. There. Okay, it's off. Then you can carry on.
I got to find it again.
Sorry.
Is it bad?
Better. We've got you on most recently
Okay.
study data, yes.
Yeah, that's it. So IDF, politics aside, they are prolific users of FTP. And when I discovered this was from their field manual. You guys have a look. It says injury mechanism, massive hemorrhage. Signs of hemodynamic compromise, systolic BP less than 80, absent radial pulses, administer 1 unit. Monitor, reassess, another one available. And this arrow then goes to the top. And it doesn't say, stop 1 unit only. It basically says, give a unit, reassess, give another unit. There is a maximum dose. We'll get to that now. But the point is that it's not just 1 bottle, it's more. This was a resus Khayelitsha hospital, taken there in the resus unit. You can see multiple bottles of FTP given, obviously more than 1 patient, but the prolific use compared to our colleague who presented in the United States using 1 bottle. And this is probably about 2015, 2016 at Khayelitsha. So we've been using it for a long time. We've got a lot of experience with freeze-dried plasma. What is the dose? So the dose is 12 to 15 mils per kilo. 70 kilogram patient, you're looking at 4, maximum 5 bottles, right? So that's easy to remember. Tygerberg trauma, I'll go through it later. We stick with 4. And then combination with our whole blood. So that's our current dose. If you look at the conclusions from one of the articles, basically what they're saying over here, if you read here with a little arrow, is substantial evidence supports the use of plasma or 1-to-1 ratio with packed red blood cells. So what are we doing at Tygerberg? We're doing a 1-to-1 ratio with whole blood, right? And the benefit of early administration in the hospital settings. So the data shows, use it. This is the dose. Look at your ratios of about 1-to-1. Okay? Here we have, this is what we want to see coming into a resus. FTP hanging in our whole blood in combination. This makes me very pleased when I see that hanging. I'm not too sure about this clear fluids. So we've steered completely away from clear fluids in trauma management. And then the next gold standard is our whole blood. Any questions around the freeze-dried plasma? Don't think so. No? Move on. So whole blood is now in 2026, and probably since 2022, the gold standard. Whole blood in trauma is what we do. So whole blood in pre-hospital civilian medicine. Again, the pre-hospital. So certain US ambulance systems, when we were in Denver, Colorado, the Denver, Colorado EMS system carries 2 units of whole blood in the fridge. Some of the UK pre-hospital, because logistically that's quite intense. If you look at, it's a lot of writing, but prior to the 1970s, they discovered, well, the platelets sell it off and make more of a server. They went from whole blood 1970 prior to going into the 80s and saying, well, okay, now we've got component therapy. Now we've got to 1-to-1. Where's what's your components, because this is what the blood banks are giving us. Right. 80s and 90s, like I said, amongst other innovations and rebirths was 200K usage and then FTP. So why did we stop using whole blood? We feel that it was a commercial gain from a lot of the blood bank services. This thinking slowly changed going into sort of 2002, 2003, Iraq-Afghanistan conflict, where the concept of using whole blood again became more popular. So the types of whole blood that we have are warm and fresh, whole blood transfused within 8 hours. So these are normally what we have. They're called the walking blood donors. We have guys within a certain unit that are cross-matched prior to any sort of altercation, conflict. blood gets taken from them, and then when colleagues get injured, they then just transfuse the warm blood. Cold and stored is what we're using at Tygerberg. So we have 8 to 10 units of cold and stored whole blood on site for us in the trauma unit on a 24-hour basis. We prefer whole blood 10 days and less. So 10 days and less is the best. It's from the data, it's got the highest level of coagulopathic factors that we need. Anything older degrades, and then you have less. So we use it up to 28 days, not 35 days. Older than 28 days, we'll discard it, but we never reach that point. So 10 days and less is the best of cold stored whole blood, and it's stored between 2 and 6 degrees Celsius. Our surgeons have mentioned anecdotally and over the years that when operating, there were less signs of a coagulopathic state throughout the procedure, which they attributed to the use of the whole blood in the resuscitative phase. And we still have that now. Surgeons are very pro whole blood. They say that they can see the difference in a patient that received whole versus packed red cells or no blood at all, which is fairly obvious. In the UK, the helicopter dust-off crews within the Iraq-Afghanistan conflict were carrying whole blood. They were the MED teams. And as you can see here, they're then giving the patient whole blood within the helicopter, which is a pre-hospital scenario. The UK major trauma centres, just for those of you that haven't worked there, they have major trauma centres. There's 12 in the UK. That are adult or pediatric or combined. That's the time in the Plymouth one in Derriford. Protocol really is start the patient with clear fluids, ringers of lactate, they move straight to massive transfusion. In the UK, NTCs don't necessarily leave in whole blood as yet, but they do have some machine. The reason I showed that picture here, so this is also a complication. So you've got this machine that gives packed red cells, plasma, and platelet that's got to be infused in a sheath. I don't know if you guys know what a cordis is. We use cordis sheaths in our patients, almost a clavin. It's a very large central line. So to use a bell cell machine with your massive transfusion protocol, you need a cordis, which seems counterintuitive because it's a fairly invasive procedure. You've got this whole device infusing what really is whole blood. So what do we use? We have our wide bore lines, possibly a cordis. We don't need the machine, and we give whole blood with freeze-dried plasma. The limitations of the use is just the efficacy of the platelets of cold storage, like I mentioned. Transfusion reactions, we had that. I haven't had a transfusion reaction since I started at Tygerberg in 2019, and 3 weeks ago on a Sunday, I was on call. We were here and we gave a patient whole blood, and he actually had a skin erythematous, raised wells type reaction, which is unusual. So that was one in many years of being given a lot of blood. And then the logistical issues of whole blood in a hospital bank. It took me 6 months to a year of motivation with evidence to the Western Cape Blood Service to actually supply us with whole blood. They wants to know why. They wants to know where's the evidence. So I had to get a lot of the evidence. We used a lot of US civilian trauma center evidence, used a lot of military evidence, and a lot of IDF Israeli evidence. And then they finally agreed. And we now have 8 to 10 units. And again, the resistance, I don't want to sound like a bit of a naysayer, but we feel the resistance is financial. They make more money out of packed red platelets, plasma versus whole blood. And in effect, if you think about it in the trauma unit, we haven't given a massive transfusion protocol in the front room for probably about 3 or 4 years. Because of our FTP and whole blood use, it's been unnecessary. The patients really only get an NTP if they go to theatre and if they're bleeding more actively in theatre. So yes, they probably lost a bit of money there. So, but the patients have benefited. Just to mention again that there's a complete shift away from clear fluids and trauma. The only exception being for rhabdomyolysis and burns patients. Massive transfusion protocol, as mentioned, occurs after the initial resuscitation phase. I'll explain on that a little bit later, and that's normally at the discretion of the surgeon and dentist. We don't, in our front room, do initiate MTPs. The surgeons initiate it because the surgeon is taking the patient to the theatre. The current SOP for hemodynamically unstable patients at Tygerberg is initial clear fluid, maximum 500 moles to charge the line, 2 FTPs, and then whole blood, and then maximum of 4 units of whole blood. So we'll look at the data. The data is shown essentially from the civilian trauma centers and the trials in the US that maximum 4 units of whole blood is optimal. Thereafter, one does need to move on to the massive transfusion protocol with balanced products, possibly using a TEG, and just seeing what you need and what you don't need. Right. So the mantra is at the moment that we don't bleed component therapy, we bleed whole blood, which makes sense. I don't know if you guys remember the old mantra where they used to say patients don't need, what is it? Salt water. Salt water is for pasta, not for patients. We now say the patients need whole blood. Any questions so far? No? So what do we do at Tygerberg in terms of our fluid therapy? So we established bilateral, large, or IV access for a cordis. Our guys we're using a cordis on most of our unstable patients. It is blind, it's subclavian. If you've got a cordis catheter in place, you can squeeze through a unit of blood probably within 45 seconds. If you don't have a cordis, you're looking at 2 or 3 minutes being squeezed. This morning we placed an IO. I placed an IO on a patient. IO is great. We had a PVA. IO, adults IO is anterior-humeral. Your veins can expand and then we can start with more bilateral IV lines. So the only clear fluids is ringers or sodium chloride. We do not use synthetic colloids anymore. So no Voluven and no gelifusum. So that's out. We know the anaesthetists are still using Voluven and gelifusum, but that's not what we use frontline trauma and damage control resuscitations anymore. We then move on to 2 FTPs. We reassess. We have them mixed up, or we put them on our little device. Give one, give another one, reassess the patient. Is he a fluid responder, yes or no? And if he's not, we then move on to our whole bloods. So 2 units of whole blood, reassess, responder, yes or no, non-responder, another 2 FTPs. 2 FTPs, reassess, non-responder, another 2 whole bloods, and then we stop. So this is crucial. The patient we had this morning, we gave our 2 transient, another 2 of these, BP picked up slightly, 2 more FTPs, and then he responded well. So then he was a responder, and then we stopped. We didn't give another 2 whole bloods. Once we get to this point and you've given 2 and 2 and 2 and 2, you need to stop, because your next step is you need to decide, does the patient need damage control surgery? If he does need damage control surgery, he most likely needs a massive transfusion protocol, right? And depending on your institution, which is over here, you need to decide what is your ratio and who's going to order it. In this institution, the surgical registrar orders it or the anesthetic registrar. Besides those 2 decisions, you also then need to make, are resuscitative efforts faulty due to poor prognosis? What we don't want is what I've got over here. We do not justify 10 to 12 units of whole blood without a disposition plan. If you're looking at 10 to 12 units of whole blood, you're in the wrong direction. You're going in the complete opposite. You should be giving controlled 4 FTPs, 4 whole bloods, and then a massive transfusion protocol, not 10 to 12 units of packed red or whole blood. So if this is happening, you're doing something wrong. And on the odd occasion that does happen, and people get shouted at and reprimanded for doing that. So it's 2 and 2, 2 and 2, massive transfusion. If you're going nowhere, you've got a non-compressible bleed, you can't get to theatre, you need to make a decision, should you withdraw care from the patient. So just to reiterate, just going back, charge your lines, 2 FTPs, reassess. 2 whole bloods, reassess. 2 FTPs, reassess. 2 whole bloods, reassess. Stop. Surgery, MTP, or prognostic or palliate the patient. MTP protocols, we won't go through it, but it varies from facility to facility and whether you've got a TEG machine or not. And that's it, really. So these are the references, if anyone wants to know, the references in terms of where we get a lot of our data from and how we do things. Right. So that was half an hour. That's not too bad.
Awesome, Hennie. Thank you. That is really, 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 really interesting. I've learned a lot listening to this, and it's really great to get some of the insights and experiences from your side as well. Thank you so much. Are there any questions? I'm not seeing anything in the chat just yet, but if you want to go ahead and put any questions into the chat or raise your hand, please go ahead and do so.
I'll just mention, I think that the problem with can you hear me? The problem with freeze-dried plasma is availability. So even in the Western Cape, so we have the CHCs, district, regional, and tertiary. A lot of our CHCs do not have freeze-dried plasma. And the thing about freeze-dried plasma, it's actually on a pharmacy. It's a pharmacy budget order. So if the pharmacy and the chief pharmacist does not approve freeze-dried plasma, it's just not supplied and stocked, whereas your blood budget is a different budget. So if you want freeze-dried plasma, you actually need to discuss with your pharmacy head or what have you to order it.
And it's not, if I'm not mistaken, not that expensive. Do you have any idea of costs roundabout, Hennie?
Yeah, so that was a lot of the resistance. It's more expensive than what you think. So I got a lot of resistance from our trauma surgeons in the beginning. They were saying, well, ringers costs 100 Rand a bag or whatever. Freeze-dried plasma, you're looking at 800-900 Rand a bottle. So now it's going to cost more, especially according to the dose you want. But the way I sort of got around that was, look, blood is on a different budget, FTP is on the pharmacy medication budget. It will balance things out. And then once they started seeing the clinical evidence, anecdotal evidence with freeze-dried plasma, and in combination with whole blood, everyone's opinion was changed.
Amazing.
I do have to say, though, at Groote C14 trauma, the trauma surgeons there's 4 trauma surgeons that do not agree with freeze-dried plasma, whole blood, or TXA. So the trauma surgeons there use clear fluids. They use a liter of ringers, maybe 2. They only have packed red cells within the unit. And from there, the next step is a massive transfusion protocol, which is different to what we're doing here. Is it because we have emergency medicine running the TEU? We're not sure. But our trauma surgeons are completely on board with what we're doing and extremely happy with the outcomes.
That is incredible. It's a huge success story as well for seeing the evidence for something, advocating for it, and achieving it and seeing really good outcomes as well. So well done to you for taking that initiative.
What we're trying to do with the EPIC study that we're running is we're looking at the data. We're trying to, being retrospective, it's not the most reliable. A clinical trial is the best, but we are trying to show that combination of FTP and whole blood is equivalent to a massive transfusion protocol. So in a resource-limited environment, LMIC countries that don't have access to MTPs could certainly have access to FTP and whole blood. So with your trauma patients coming in, if you give them FTP and whole blood, you can feel relatively reassured it's almost as good as a massive transfusion protocol.
Can I see by show of hands, for those who are in the room, how many of you have access to freeze-dried plasma, to bioplasma in the units that you are working in? Assuming that most of the doctors here are working in the rural areas. I know at least 2 are from our unit, so we do have access, but we are, are a tertiary hospital in an urban setting. Anyone from the rural hospitals who's got access to freeze-dried plasma where you're working? Not seeing any hands there. So that's, definitely something to think about. I remember trying to advocate to get it actually in a pre-hospital setting when we were working I'm seeing Dr. Demony raising her hand, working in the Northern Cape and going through a process there. So it is possible. And this is a lot, many, many years later to that as well. So please feel free to get in touch with either me or Dr. Lategan, if you don't mind, Hennie, and let us know if you need some help with advocating for that process and trying to get it in your areas. Especially if you're in the Eastern Cape, we can potentially assist as well from Livingston side.
Yeah, I mean, I worked in Northwest in Rustenburg, and we had freeze-dried plasma there from the same company, Plasma. So since 1995, it's been available in South Africa, and we are actually so privileged, I would say, in this country that we have our own manufacturer, and we've got it available. People just need to ask for it, and I think the awareness is out there. You need to request it, get it on your I don't know what they call it, where you can order it from the States. But the main thing, it's a pharmacy order. That's the main thing.
Yeah, and so it doesn't form part of your blood budget.
Yeah, exactly right.
Hennie, I've gone ahead. Sorry, just for everyone here, I've just gone ahead and put up a poll. Please go ahead and have a look at the poll for. Sorry, excuse me. That was the week 3. Excuse me about that. It's week 7. Sorry, guys. I don't know why I keep thinking it's week 3. 1 second. Let me just close that and launch a new one. Excuse. 1 second. And then, Hennie, can I ask you a question about? You mentioned earlier. The using clear fluids in your rhabdomyolysis patients. So it's obviously quite common. We actually had a patient this morning in our unit to have patients who, especially if they're undergoing community assaults. I see you guys have also recently published from your EPIC study on that as well, the high rates and how they do respond and how you've been managing them. But in terms of, you have obviously their polytrauma, sick, bleeding patients, they've been injured, intra-abdominal bleeding, often head injuries, external bleeding, and then combine that together with a rhabdomyolysis type of picture where they've got more than, sort of a certain amount of body surface area that's affected and they're already going into renal failure. How would you manage those cases? Are you giving your blood components, your blood therapy and your FTPs together with your clear fluids, or what is your sort of protocol at Tygerberg in those cases?
Remember with the rhabdomyolysis, it's not so much about. We found that stakes and SOPs we don't like are the ones that say give 2 liters stat, then give another liter after an hour. The rando patient 1 to 2 to 3 mils per kilo. Again, to do your. Can you?
I've lost you for a second. Sorry, can you just repeat? Can you just repeat what you started again?
FTP whole blood, make sure the urine output is 2 to 3 mil per kilo per hour. So what we'll do is we'll give, if they hemorrhaging patients and they've got rhabdomyolysis, we would give the FTP the whole blood, including clear fluids,
Okay, Hennie, I'm losing you again. I think I don't think it's, yeah.
Probably down.
Hennie, I've lost you completely there. Can I ask a huge favor? I don't know if you're still with us.
Yeah, I
Would you
lost
mind
you.
putting that?
You,
Would you mind putting that into the chat? I think it's just a little bit of
yeah,
signal that
yeah.
we've just been losing right there, and I just not hearing exactly what you're saying there. And I think it is important. While we do that, does anyone else have any other questions? Any other questions for Dr. Lategan? Great. Then please, for those who are still here, please go ahead and answer the poll. Have a look out for Hennie answering that in the chat as well. So we're just waiting for that still.
I just couldn't find it. There's the
Oh,
chat.
now I can hear you just fine again. It just seems to be coming and going. I don't know if it's the hospital.
So, all right. It's 223 ml per kilogram. Okay. That's the most important marker.
You're saying for rhabdo, you're looking for urine output of 2 to 3 mils per kilogram per hour. Yeah.
It's the most normal urine output is 0.5 ml per kilo per hour. So you want 2 to 3. So if you have a combination of polytrauma with rhabdomyolysis, active hemorrhaging that needs whole blood FDP, you can then titrate your clear fluid. What we would normally do is we give clear fluid at 250 mils an hour if they're not hemorrhaging, with no blood products. If they are hemorrhaging, we'll take our clear fluids down to 125 to 150 mils an hour with that FTP and whole blood and monitor the urine output.
Okay, I like that. Okay, so you're sort of almost halving your clear fluid rate and titrating, still giving your blood therapy, but then aiming for that 2 to 3 mil per kilogram urine output as you go and titrating and putting the two together.
Yeah, and just in general, we must stay away from adrenaline and trauma patients. I see far too many junior docs. They get flustered.
Yeah.
The blood pressure is low, and immediately call for adrenaline, but the patient hasn't had the proper fluids that they need. It's also where EPOCUS ultrasound comes in. We do IBC measurement, GCS, cap refill, pulse. You know, all those parameters before you give adrenaline. See a lot of guys starting adrenaline and it's completely wrong, and that pushes them into renal failure.
Yeah. Yeah, very little role for adrenaline in trauma.
Yeah. Do you have FTP in Port Elizabeth?
Sorry?
Do you have freeze-dried plasma?
Yes, we do have in our front room, yeah. We don't have whole blood. And so I'm interested in your story and seeing to advocate for it. It has been a no every time. We haven't really tried that hard. So I'm wondering now if it would be a possibility to look at. But we have FTP and we use it as first line in our trauma cases.
Yeah. I think as more and more evidence comes out for whole blood, although the evidence is there, people are just not used to it. They need to start using more and more whole blood.
Yeah. That is great.
Okay.
Right.
I don't think there's any question.
Are there any other questions? Anything else anyone wants to add? Great. Then Hennie, thank you. Thank you so much for being available this evening. Thank you for sharing your wisdom with us, and thanks for sharing your experience with us as well. Really, really appreciate it. Thanks to everyone who joined us this evening. Thanks for also giving up your time. We know that you're busy wherever it is that you are working, and grateful that you came to join us this evening. Hope it was valuable. Hope you learned a lot, and we will see you all at the next one.